Welcome to episode 1 of Community Health Worker Data Dialogues, the podcast where we dive into how data is transforming community health worker programs around the world. I'm Dr. James O'Donovan, Director of Research at Community Health Impact Coalition, and I'm joined by my co-host Dickson and Sima Mbewe, a community health worker from Malawi. In this episode, we're going to be speaking with Dr. Madeleine Ballard, CEO of Community Health Impact Coalition, and Tracey McNeill from the Gates Foundation to explore how data is shaping the community health worker landscape. But before we get into that conversation, let's start by hearing directly from some of our community health worker colleagues about the work that they do and the role data plays in their daily lives, including Bernard from Kenya and Alicinia, Renata and Valeria from Brazil.
Okay, as a community health worker down there, when we talk about data, we have several types of data that we need to connect or we collect in the community. But one that I would mostly talk about, particularly in relation to where I come from, is on malaria. I come from an malaria endemic area where you find that we have a lot of malaria cases, and you will find that it is that data that informs whatever is done in the community level. It will inform on the number of drugs that is required in the community. It also informs on maybe the kind of services that need to be done for us to ensure that malaria is actually curbed at the community level. So malaria, data involving malaria is actually the most important that I would consider currently in my area.
A coleta de dados ela é muito importante.
So, data collection is very important because it's through this data collection that we can do monitoring and planning of activities for the clinic and the community. In the case of hypertensive people, diabetics, pregnant women, now that it's February and there are carnival activities, we are dealing with sexually transmitted diseases. All this data collection brings us a guide for how to include this population, this community, in the services the clinic provides.
E esses dados eu creio que eles são de
I believe this data is of fundamental importance because only with this information can public policies be made. I believe the role of the community health worker is crucial because we live in the community where we work. So we know the peculiarities of this community, the hopes, the singularities. No one knows the family of that space. No one knows them better than we do.
Now that we've heard from the community health workers, let's go to the studio and hear from Madeleine and Tracey about how they started working with community health workers.
So my story with community health workers began in the 2000s. I was originally from Canada. I moved to the United States to go to university. And at that time, there were actually waiting lists for HIV drugs, which was a real shock to me. I'd grown up my whole life just hearing about how rich and powerful the United States was, and it really felt like they weren't necessarily using their power for good in this instance, right? Because if you take HIV drugs, you live a long and happy life, and if you don't, you're actively dying. And it felt like, this is in the 80s, these drugs have been around for a long time, why don't people have access? And so I got involved in the HIV movement, and it was really those transnational networks of solidarity that led me ultimately to work in Liberia as the founding program manager of Plasma Health in an area so remote and so dangerous that actually the UN peacekeeping force in the country at the time didn't even patrol there. They said, here's a satellite phone, good luck. And that was basically people who were living there. That was the response that they got too when they wanted access to care. It was kind of like, good luck. And even though there were community health workers in these remote areas, they didn't have the support they needed to provide great care. And so that was kind of the subject ultimately of my doctorate later. Why, when there's, all this amazing evidence about how community health workers can save lives and reduce the amount of sickness in a population, do these national programs in so many countries, not move the needle in the way that we would expect? And I think the answer is kind of what I described both, in the States and in Liberia, is community health workers are not getting the support they need. They're not getting salaries, skills, supervision, supplies. And so that was really the genesis of Community Health Impact Coalition, which is now this kind of 60-country movement of community health workers and organizations who are making professional community health workers the norm and ensuring that there's health for all, including those who provide it. And we work together with funding entities like the Gates Foundation. And so I'll hand it to Tracey to tell us her story.
Great. Welcome, Tracey. Nice to have you here.
James. Thank you. Thank you. So first of all, great to be here. And I also think so important to have Dickson here. We can talk about community health workers, but actually Dickson's actually doing the work and delivering it. So fantastic that you're here, even though it's so cold in London. So when did I first start working with community health workers and in this kind of space? I've been involved in delivering healthcare for decades, actually more decades than I care to remember, and started as a frontline healthcare worker myself. I trained as a nurse. And I think that that also taught me the importance of frontline work. And then when I started working in global healthcare, which was mainly delivering sexual and reproductive health in sub-Saharan Africa, then I began to really understand the role of community health workers, spending time with them, out in the field with them. And I think there's been so much development. That's probably 20 years ago. So I look today at someone like Dickson and how far the work has come with support from organizations like those led by Madeleine. And I think then I was very privileged to live in Rwanda. I went there to set up a digital healthcare solution for the entire population of Rwanda, and then worked very closely with community health workers. They're very well organized in Rwanda. They're delivering frontline care, but I learned such a lot from them, and also learned about the types of tools they require, the data they require in order to help support them succeed so they have the right tools. So for me, now fast forward to the foundation, the Gates Foundation, then we invest significantly in community health workers because we believe that actually by providing them through our partners with the resources that they require, then you can go to the last mile and you can really actually get to those mothers, children, adolescents, patients that really need care delivered to them where they are and meeting them where they are. So I feel very privileged. I've had that experience over many decades.
That's fantastic. That's fantastic. Thanks both for that amazing background.
Yeah, thank you so much for your good explanations, Madeleine and Tracey. But I would also like to ask some few questions. In your current positions, what are the main priority areas or areas of focus when it comes to working with CHWs? And also, in what ways does data help in achieving these priorities?
I think fundamentally for the coalition, data are about dignity and empowerment, right? Patients, all of us, deserve health systems that work, health systems that are evidence-based, health systems that produce great outcomes for us and for the people that we care about. And so data, when it's high quality, when it's available, empowers, as you know, community health workers to do their job with excellence, program managers to make smart decisions, and ultimately policymakers to invest in models that produce the greatest effect for all of us. And it's only when we have these up-to-date data and we can see across a whole health system and a whole country and even the globe that we can tell, are the right interventions getting to the right people at the right time? Are we covering everybody? Are we reaching them with the speed that matters? I mean, things like malaria kill folks maybe in a day or two. And so speed really matters, not just that we reach everyone, but we reach them in the right time. And then the quality of care. It's really easy to make a small mistake that can have really profound outcomes. And so if we're tracking those mistakes, we can correct them. But of course, as we know also, none of that is possible unless we have things like salaries being delivered on time, supplies in stock, and so that underlying infrastructure is important to track as well. And if we have all that as a package, then I think we're able to provide dignified care and have folks empowered to make great decisions to keep improving that care.
I guess talking from the foundation's perspective, then we invest a lot in data. And we don't invest in data because we want the data. I think what's really important when you look at data in the work that community health workers do is that providing data that actually supports their work, so supports them to deliver care at the right time, in the right place, and to be able to go the last mile. What I often see as data systems are really fragmented. I see many people like Dickson who have 4 or 5 different handsets trying to enter data for malaria or maternal and child health, etc., etc. So I think what data really means for ours as a foundation is making sure that we have data that's telling the story about the work that's being delivered, understanding where the gaps are, and where we can do better, either in terms of coverage or quality, or we're not getting to very remote populations. So for me, data is really telling you a story. But I think that what we need to make sure is that organizations like ours are not developing data just for ourselves. So ultimately, that data has to be used in terms of improving patient outcomes and supporting CHWs like Dickson out in the field. So much of our work has been around trying to break down the silos and make sure that there isn't fragmentation, make sure that we can streamline services. So as an example, we've worked really closely with community health workers in Indonesia. There was 200 to 300 apps in existence in the community, and we've reduced those down very, very considerably through government-led programs, through partners. So I think if I summarize, for me, it's about data to improve service coverage, to support individuals out in the field like Dickson. It's to simplify that data, and it's also to learn and improve services as we go forward.
Thanks, Tracey. That's fascinating. In fact, I just wanted to pick up on that point around 200 to 300 apps is overwhelming. Just hearing you speak about that, and I can imagine how siloed and fragmented and almost like a patchwork landscape that occurs because of that. I just wanted to pick up briefly on that point and ask, practically, how do you go about trying to reduce those fragmented landscapes? Because, from my own experience, I've seen that happen myself in Uganda. I'm just really interested practically, how do you go about doing that?
Sure. I think there's a few ways, James. Often, the world in which we work in global healthcare is awash with pilots. I ban the word pilot, and I talk about pre-implementation, because then it's leading on to something else. So I think often the apps are piloted and they actually don't go anywhere. So that's kind of one group. I think the second group is that they lack interoperability. So they're standalone. Dickson, I think you can probably talk about this much better than I can in terms of having apps that stand alone, that don't talk to other apps. They're not interoperable. They're not sharing data and material. So again, that's another group that unless you can make them interoperable, they're actually not helping anyone. They're just feeding someone else's data. They're not helping Dickson in his day-to-day work. So I think there's various ways. But at the end of the day, I think you need really strong stakeholder engagement from ministers of health, from government, but also you need the buy-in and the motivation, and you need to talk to the frontline workers in terms of what's going to help them and what's going to make their life easier so they can focus on delivering care rather than feeding 10, 20, 30 apps all at one time.
No, that's fantastic. And actually, I'm really glad you touched on a lot of those points, because Dickson and I are going to pick up on all of these. Episode 2, we're talking about co-design. Episode 3, we're talking about the use of digital and data and interoperability. So we're really excited that you've touched upon those points so early on in this podcast series. And again, so many points resonating here, especially around what I call pilotitis. In fact, in Uganda, I think it was back in 2015, the government placed a moratorium on e-health or mHealth apps because there were just so many that were proliferating through the country. Okay, so Dickson, you're a community health worker. Tell me a little bit about who a community health worker is and the kinds of roles and jobs you do day to day.
Thank you, James. Yes, my name is Dickson Nansimambewe. I'm a community health worker working with the Ministry of Health in Malawi. just a brief background on what the community health worker do. There are a lot of roles that have been signed to a CHW, especially in Malawi. That's to say. Some of the roles are like we do disease surveillance, we do vaccinations, we do home visits, we do TB screening, we do nutrition assessment, and also we do data collection. So all these roles are put to a CHW to perform and also to give a report at the end of the day. So in terms of data, yes, it's very important to have a data segment in a CHW roles. For example, you go in the community, you find that there's an outbreak. So you have to quantify, you have to know how many people have been infected or what's the magnitude of that infection. So without collecting data, you cannot give anything to the top management, and also you cannot have accurate interventions on that infection. So yes, data is very paramount in community health work, and also it gives a guide, and also it brings good policy making strategies to say what can we do to improve the lives of the communities. Because, James, at the end of the day, whatever we are saying here is to improve the lives of the communities. Yeah, if there are any infections, if there are any outbreaks, we have to break those chains, and also we have to bring back the normal health of the communities. Yeah, so in brief, data plays a key role in improving the lives of the communities wherever we are serving them.
That's amazing. I'm just struck there, Dickson, by just how much you do. It's like an unbelievable amount. And yeah, I think what you're doing is obviously incredible. And you are the person who's kind of going to those doors, households, calling on people, providing life-saving care, basically. I know we've talked a little bit there about how much data you're collecting, and it honestly sounds like endless amounts of data for many different types of illnesses or disease burdens. So, maternal and child health, infectious diseases, non-communicable diseases. I don't know if that ever sometimes feels a little bit overwhelming in terms of, are you being asked to collect too much data, or are you being asked to do too much with your role?
Yeah. If you can see what I've said, or maybe if you can analyze what I've said, you can see that it's a lot of work that we CHWs do in the community.
That's the understatement of the year.
But we have to do that because there's nobody who can do that. So yeah, in terms of how much or how do we do that is a matter of planning. Yeah, you plan to say, today I'm going to collect data for this, that, this, that. So according to the need of the people in that community. So yeah, sometimes the data is integrated. So you might go in the community to collect data for maybe water and sanitation. At the same time, we are collecting data for the immunizations, data for maybe outbreaks, as I've already said, data for maybe TB screening, nutrition assessment. So sometimes the tools are integrated in nature so that when collecting that data, you just do that at once. Then you go back and analyze whatsoever has been collected.
That's really helpful. And I think it brings us into actually a nice segment that I want to ask Tracey about here, which is we've obviously spoken about all the data that's being collected. But in terms of where that data is eventually stored and, why those platforms are important, can you tell us a little bit about community health information systems and what those are? And I would love to hear from you about that.
Yeah, sure. So I think Dickson's created a great picture about, how that data is collected. I think that often the work that we're involved supporting in the Gates Foundation is actually helping that data being collected and put into a central repository where it can actually be used. And that's what I call kind of performance management data and management type data. So if you think about the data that's being collected by Dickson, what we often do is support governments and key stakeholders and Ministry of Health task teams to be able to manage that data to help improve performance. So, for instance, we can see from some of the data collection if supplies are on the shelves, if essential medicines are not reaching the last mile. And so the data that we receive from frontline workers will go to a central repository and is collected. And then I've said in many meetings, Pakistan is a very good example in Sindh, where the Minister of Health sits once a month with all the district managers, and all of that data that's collected through frontline workers and through independent monitoring comes to a central point. And so, for instance, if there's an issue with water sanitation, then that can be flagged and resources can be prioritized using the data. And so I think that where we see data is most valuable is when it's collected, goes into a central repository, is stored securely, but is used by decision makers in terms of improving performance, better allocation of resources, making sure funding is flowing down the system and getting to the right place at the right time.
Right. So thank you for describing that so eloquently. It's really amazing that you were able to summarize such a complex topic so quickly. But Dickson, do you ever get feedback from this? So say you're out in the community collecting data and you're doing something on a water sanitation hygiene project and you're inputting data into your smartphone and you notice a problem and you feed that up to, say, whoever you're feeding the data to. Do you ever get feedback on that if you notice there is a problem?
Not all the time, because when we collect the data, it starts from the community. Then you take that same data to your local facility. Then the local facility will take it to the district facility. Then it goes up to where it ends. But when it comes to give feedback directly to that specific community, it's not like that. We expect when you collect data to community A, you have to get the feedback to the same specific community A. But data comes as a general feedback, maybe for the whole district or for the whole country. So it doesn't really reflect what this data is aiming at, especially at the specific community. So it's difficult to bring up the interventions to that specific community because the data or the feedback is just generalized most of the times.
It's interesting because Tracey was talking about these central data stores and ministries making decisions based on that data. And I think that both Dickson, and Tracey, that these data are often incomplete, right? Because it's like maybe it's data from these health facilities, but not these ones. Or often it's data from health facilities, but not work that's happening out in the community. And so I think that's another piece of this is how do we actually make sure that it's not just, doctors and nurses that are counted and the patient encounters that they're having that are being captured, but that community health workers are counted as well, and all of their, whether it's, like you said, TB screening or some sort of epidemic or disease prevention, that data is being captured and then is also able to be kind of fed back to communities for decision-making, preparedness, etc.
Yeah, I think that's a really important point you've just made there, Madeleine, about, counting community health workers. I know that we often think of data in the sense of, or traditionally, maybe the community health workers going out and collecting data on certain diseases or, maternal and child health. But I think you've made a really important point there about if we zoom out to a more macro level, you've got the idea of counting community health workers themselves and actually getting accurate data on, who are community health workers? How many community health workers are there? Because they're all doing this amazing work that you're doing, Dickson. So can you tell us a little bit about that in terms of, is there any work being done to count community health workers?
Yeah, I think people find this a bit astonishing in its basicness, right?
Right, yeah,
Because
exactly.
folks just assume, well, yeah, if you've got a doctor, or you have community health worker, maybe providing vaccinations or treating patients, then the health system knows who they are and where they are, right? And I think, unfortunately, the answer is sometimes. And so in order for these central data stores to be complete, in order to have a community health information system and have community health data being reported and to have a complete picture of what's going on in the country, you actually have to count not just the facilities, but the workers in facilities and beyond facilities. And I think something that many listeners might be surprised to know is that often the people who are providing care, the community health workers who are providing care at their neighbors' doorsteps, are not actually counted by the health system. And this causes a lot of problems, and Dickson's nodding here.
Yeah.
And he can maybe add on.
Yeah.
What sort of problems does it cause for you?
Yeah. Actually, just want to add on what we have said. Yeah, you see, a CHW has been involved to collect data, but is not involved in the designing of that, maybe the questionnaire or whatsoever has been provided for that data to be collected. So it's like we are just using a CHW to collect what we have suggested, but this one has not put his or her inputs on the way how we are going to collect data. So sometimes you may miss some of the important areas just because you haven't involved the one who is on the ground. You have just suggested, if you can do this and that, we can get the right data, but yet it's not the way you can do it.
And
So
Dickson, just to clarify, are you employed by the Ministry of Health in Malawi, or do you work for an NGO? Like, who pays your salary, and do you receive a salary for the work that you do?
Yes, that's a good question. I've been working for the Ministry of Health for 19 years.
Oh, wow. Okay.
Yeah, so I'm paid by the government of Malawi.
Okay.
I know about all community health workers. Been working for 19 years is not a joke. I know everything. Some were not born by then up to today. They are born. We have been working.
Right.
So yeah, just to answer your question, I'm employed by the Malawi government.
Okay. And Madeleine, is that always the case? Are community health workers always, employed by the government, which would make it easier to know how many community health workers there are? Can you give us a sense of how this works?
Yeah, so I think, and Dickson can speak more to this, because I think Dickson's also not just a caregiver, but a community health worker organizer. Maybe we'll get into that a little bit later on. But Malawi is an interesting case because Malawi actually recognizes many community health workers as civil servants, and that's extraordinary. But actually at Community Health Impact Coalition, we have a map of the world that we call our professional community health worker dashboard, Pro CHW dashboard. And if you look at that dashboard, you'll see about 100 countries, and you'll notice that in 60 of them, community health workers are not actually recognized as salaried, accredited professionals. And so what does that mean? If you're not in Malawi, maybe you're in a different country, and I won't... you can check out the maps.
Yeah.
Everyone's trying their best here, but I think there's room to improve. And I think in the majority of countries still, we have the case where community health workers are informal. So we think of them and we rely upon them when there's an emergency, or when we need to do a vaccination campaign, or when we need to distribute malaria bed nets maybe. But day to day, they're not actually recognized as part of the health system, and therefore they're not counted, and that creates a lot of problems. And actually, to give you a sense, the first ever guidance on how to count and track community health workers was published only in 2021, which is astonishing because community health workers have been around for about 100 years. And the reason that we have to have special guidance on this is because, health facilities, they don't move, right? So it's easy to track where a health facility is. Whereas Dickson might be covering kilometers and kilometers, visiting multiple different communities. And it's a little bit more complicated to figure out where an individual person who moves around is versus a building. But that guidance now exists. It's called the Community Health Worker Master Lists guidance. And it's basically an invitation for ministries to say, hey, let's actually figure out where all these community health workers are, who they are, what their name is. It's Dickson. What's your phone number? What training have you received? Because I think in the context of informality, some community health workers might be trained on malaria one year, or they might see a PowerPoint on TB another year, but it's not unified, and not all community health workers are equipped, even though we know they can do, as Dickson was saying, a million different things. They're not all equipped with that same standardized ability to provide standardized care. And so Community Health Worker Master List is really that first step to sort of saying, who's out there providing care? What do they know? Are they active? And what do they need? And I think this really came to a head, this work actually, you'll notice 2021, it came to a head during COVID, because all of a sudden it was like, wow, community health workers are the front lines in mobilizing, and in the case of Malawi, actually providing COVID vaccines to countries. And they should themselves, as health workers, be vaccinated first and provided with personal protective equipment. But oh my goodness, all these countries didn't know where they were, who they were, and so they were not able to include community health workers in that personal protective equipment projection or vaccine equipment projection. And so as a coalition, actually, we worked really rapidly with a number of countries to develop rapid estimates and to ensure that community health workers were protected and vaccinated and able to carry out that work. And that kind of laid the groundwork for, okay, maybe we need just some guidance here so that countries can actually set up this infrastructure so that we're ready when Marburg or Ebola or the next pandemic strikes. I think, if you want CHWs to count, if you want patients to count, you got to count CHWs. It's as simple as that.
Exactly. I mean, thanks for sharing all of that. It does seem like a mammoth task to count community health workers. And you said that you did some of this, obviously, during the COVID pandemic. Can you give us a sense? It sounds a bit overwhelming at the moment, but how did you go about doing this practically?
It was a really cool collaboration, actually, because I think it was, and Dickson, you can come in here too, but I think community health workers have been advocating for a long time to be counted. And there's a lot of allies in this fight. And I think this was just the moment that we were able to seize and sort of say, see, we told you this was important. And now what's been a problem for patients and community health workers is now a problem for all of us because we're not able to get this pandemic under control. And so it was really just an opening where we said, hey, actually, let's push forward and get this guidance. And again, I think when folks hear the word guidance, they think, it's kind of boring and technical. But it's actually really powerful because it's the blueprint for hundreds of countries around the world in terms of how they design their health system. And so if you look up this guidance, it's not just from us, it's from UNICEF is an author on that guidance. The Global Fund to Fight AIDS, TB, and Malaria is an author on that guidance. And it lends that credibility to sort of say, hey, you, as a Minister of Health, you don't have to go out on a limb here and design something from scratch and take a big risk. You can actually just follow the very simple steps that are laid out here. Contact the folks in different countries that have already done this, look at the case studies, and see how these very comparatively small investments up front in this critical infrastructure, community health worker master lists, that then allow you to have community data, community health information systems, and robust health data about a whole country, can help you not just treat, a sick kid in the rural rainforest of Liberia today, but actually enable you to almost switch on an active, gigantic network of, as Dickson was saying, pandemic detection, preparedness, sentinels, and all work together to be better prepared for the next pandemic. And I think no one really wants to talk about the next pandemic because we all just got through COVID, and we're still, I think a lot of us are scarred by that experience still. But I think the reality is we know that next pandemic is coming sooner, especially with climate change and in these increasing crossover events between animals and humans, the world's becoming a bit more of a viral playground, and so I think we have to be ready. And these are one of the key investments in our people and our health across the world that can help us be ready.
Yeah, I think your original question, James, about to Dickson about who's funding community health workers, and so in the Malawi example, which is a very good example, that it's funded by the Ministry of Health. But I think some of the work that I see through the foundation is there's excellent work with the registers done by the coalition. But I think that often community health workers are funded by very well-meaning organizations who are looking at single disease verticals and interventions. And I think that in the past that's worked to some extent, but I think that what we're trying to do through our partners in the foundation is really make the work of community health workers sustainable. And for it to be sustainable, it needs to be really funded within a government system. Community health workers, they need the training that Madeleine articulated and Dickson did. And they need to be seen as a professional part of the whole healthcare delivery system. And I think through experience, most of us sitting here today will know that the way to do that is through supporting government's key stakeholders so that they become part of the Ministry of Health healthcare teams, and we move away from the disease verticals and the fragmentation that we've seen in the past.
Right. No, that's super interesting. And why? So in the past, you said you might have funded more sort of these vertical or disease specific interventions. Why have you started to move away from that to funding these more horizontal programs? And as a funder, would you still fund vertical interventions, or would there be any scenarios where that would work?
So within the foundation, we still fund vertical programs. So, a key objective of the foundation is eradication of malaria and polio, for example. So we will always put funding in those verticals, reducing maternal mortality as an example. But I think increasingly we're working horizontally. So I represent the primary healthcare work within the Gates Foundation, and that's definitely horizontal. And the reason we're doing that is that, there's only a finite amount of funding that's going to go into global health care. And we all know that that's a difficult space at the moment. So I think we all need to think about being more efficient. And we need to think about programs that are sustainable. And we need to think about programs that are integrated. And so, again, an example of some of the work we're doing in Indonesia is the community health workers are trained in 25 different interventions. We're bringing that all together into one training program, into an integrated digital system. But importantly, we're giving the training and the professionalism to those frontline workers to be able to deliver and go into homes and in one visit. And I was very privileged to go to a very remote part of Indonesia and actually go out with a community health worker and actually see them sit in a home and do things like water sanitation, check hygiene, check nutrition, and so on and so on. And so I think that's a model that I think that we need to think about, that is funded through the government and supported in the early days by organizations like ourselves, but only where there's a path and a roadmap to sustainability.
And just to touch on Madeleine's point around counting community health workers, as a funder, is that kind of data useful for you at Gates?
Yeah, well, yeah. So we should never be collecting data for ourselves. But your question is really valid. So collecting that data is important, because it's important that ministers of health know how many workers there are out in the community, and Madeleine explained that. We're often funding, whilst you would assume that ministers of health would know where all the bricks and mortar primary healthcare facilities are, they often don't, or they may not have a roof on, or they may not have any staff. So actually collecting that very basic data that we would take for granted in sitting here in London, in the kinds of environments that we work, that data isn't available. And for me, that's the baseline of primary healthcare, is understanding how many staff you have, where they are, what is it they're doing, how can they be better supported. And I also think that one of the best systems I've seen was in India, for example, where the community health workers are very strongly supported by the primary healthcare facilities. So they have digital tools. If they come across a pregnant mother that they're worried about, they can immediately escalate that case through an app straight through to a midwife, and that patient can then be referred. Also, the same tool was providing education programs for women and the community health workers. So I think, again, there's a role for organizations like ourselves in terms of understanding where innovation is going and how we can better support frontline workers and Dickson to help him do an even better job, even though he's doing an amazing job already.
No, thanks for that. I think, again, both of you have touched on a really important point that, look, we need to count community health workers. And often it seems difficult because it is easier maybe to go to a health facility and say, look, there's a health facility here, a health facility here. But actually counting community health workers who are going out, delivering the primary care door to door can seem a bit daunting and challenging. And Dickson, just in the sense of, give us a flavour as how far you might travel to see patients and how many colleagues do you have that you directly supervise and support?
For me, I'm also a senior community health worker. I'm also a supervisor. Currently, I'm supervising over 100. That's inclusive CHWs, that's community health volunteers. So if we talk of the work of data collection as the combined figure, there are other challenges that we meet. Sometimes about the knowledge on how to use these data tools. Most of the time, a community health volunteer maybe is just picked from the community, does not know anything about what is data, how can we use data, how can we analyze data. So it's a very big figure of them. So most of the times you may send this person to collect data at a certain community. As I've already said, maybe cannot use the digital tools, find that the data is much questionable to say what are these things that have been brought. So I think the other thing is like we also mobilize from these donors and funders maybe to put more resources into the government budgets. So that, because what I understand now, you say if you go to the Minister of Health to advocate for more CHWs to be employed, they will say, look, we don't have funding, we don't have money. Where can we get the money to pay these people? You know, we have got a lot of climate change issues, flooding, so you really sometimes understand to say maybe this government can do that. So maybe the other thing that we can do from now is to advocate more from these donors, funders, so that can pump a lot of money into the government systems, so that maybe they should not have anything to say, maybe to defend their case, to say we cannot employ more CHWs.
And I guess that's where like counting community health workers is so important. So you can let governments know, look, there are 20,000 community health workers that are working to deliver primary healthcare services. This is how much money you're going to need to support them properly. And that's where the benefits, again, of Master Lists would come in.
And this is the value that they're creating. I mean, Tracey mentioned Rwanda at the top of the episode. And, community health workers in Rwanda, they're treating half of all malaria cases in the country.
Right. Wow,
they're not taking up half of the health budget, you know? So this is really a great value for money investment for that governments can make.
I mean, it seems like a no-brainer to me. Just when Dickson, you were explaining the vast array of things you do: TB services, WASH services, maternal and child health services, and you're delivering this for incredible value. So yeah, I completely agree. I think, look, this has been a fantastic conversation in terms of just covering the breadth of the role community health workers play, the importance of data, how data is collected, community health information systems, counting community health workers. There's an incredible amount to take away here, and I'm really looking forward to seeing how we can build on this in future episodes. Tracey, what would be, I know it's maybe difficult to say, but what would be one key takeaway, one interesting thing that's come out of this conversation for you?
So for me, it's always hearing from someone like Dickson, because we can talk about the work and we can be very enthusiastic about it and very committed to it, but it's actually Dickson who's doing it. So I think, the importance of this session is really, learning from Dickson, understanding what happens in malaria, which is a really bright spot, a bright star. And so a key takeaway for me is that, the way to move this work forward is for us also to listen.
Right.
And to listen to those that are hands-on delivering care at the front line, and for us to understand better how we can provide the support that is so much needed in this crucial area of delivering primary healthcare and global healthcare. So my key takeaway is to thank Dickson for being here, being such a superstar, and keep doing what you're doing, because it's brilliant.
Thank you, Tracey.
And Madeleine, what about yourself?
I'd build on what Tracey said and say that when we listen, we make progress. Dickson is one of many community health worker organizers around the world who've brought together community health workers to advocate, as he said, for everything from salaries to supplies to just really a seat at the table. And if we just take a look at, what we've been talking about in this episode, right, which is community health worker master lists, count the CHWs so that you can count the patients, community health information systems. There's been tremendous progress even since 2021. When we wrote that guidance together, I think 2/3 of when you looked at the global estimate of community health workers, we didn't know what it was. It was based on data from less than 100 countries, and 2/3 of that data was out of date, 5, 10 years older. Now, just a couple of years later, we have data, the WHO has reported data from more than 100 countries, and the proportion has flipped. Now it's only 1/3 out of date. So, I think that's definitely not good enough. And we need to recognize that when we come together to do research and we change guidelines and we change funding and we change policy, that a lot of progress can be made in a very short amount of time. And it's CHWs at the front, wielding those numbers for change. So, yeah.
That's fantastic. Dickson, what about yourself? What's come out of this conversation for you?
Yeah, it has been a great conversation. Actually, I've learned a lot from Tracey, from Madeleine. We are at the end of everything as CHWs. Most of the times, maybe our voices are not heard just because some people wish not to be heard, for us not to be heard. But if we are like here, like Tracey, Madeleine, we know the voices that I've made have just gone straight to the people who are supposed to get the message. So this is very, very important. Most of the times decisions are made without CHWs who are on the ground. You find they bring up some of the interventions that maybe not give an impact to the communities. If we talk of primary health care, we talk of those services that are accepted by the communities. So if a CHW is not involved in the decision, then we are taking these interventions from somewhere, not from the communities, which will not give any impact to the communities. So I'm just so happy that we are here. We have discussed a lot. You have heard from the horse's mouth what is on the ground. Yeah. So this is so great to me. I appreciate this.
I just wanted to ask, and again, I'll ask everybody this question. If you could have a call to action or a message to funders of this work, and I know, Tracey, there might be some bias here for you being one of the donors, but in the context of data in community health worker programs, what would that be?
Yeah, I think that's a really good question, James. I think that what I often ask when I'm in the room with other donors, funders, is let's reduce the fragmentation. I talked earlier about, there are finite resources going into global healthcare. We're very lucky in the foundation that the foundation is very generous. But I think that we can do better. We can be more efficient. We can use the funding in a way that we're much more integrated as funders. We can remove waste and duplication. And then we can better reallocate those resources to where it's really needed.
That's fantastic. Yeah, I think you've really hit the nail on the head there. Yeah. Madeleine, similar question to you. I don't know if you've got the same answer or...
Yeah, no, I would just build on what Tracey says. I think so often there's a desire to rush ahead. Oh, let's go train community health workers. And yet a failure to create the infrastructure for caregivers to thrive. Right? Unless you have counted CHWs, unless you've equipped, as Dickson was saying, community health workers with 1, not 4 data collection devices that go to 1, not 17 databases that are used by one unified council of decision makers and fed back to the community health workers, you're not yet at the stage where you can be training anybody on anything. And so I think at this point, there's so many wonderful examples, case studies, guidance on how to set this up, how to set up community health worker master lists, how to equip community health workers to feed into a community health information system that's connected to the broader health information system, and ensure that community health workers are, as Dickson was saying, kind of salaried and equipped and ready to do the best that they can for patients. And we know that when community health workers are treated like professionals, that's when the most lives are saved. So let's get that data infrastructure in place. And first things first, and everything else follows from that.
We hope that you enjoyed this episode. If you did, please consider sharing it with a friend or a colleague, and please leave us a review wherever you get your podcasts. It really helps others to find the show, and don't forget, episode 2 is now available.